one, go.
Well, good evening, everybody. Time here in Denmark is 6 o'clock, and in the Emirates, 8 o'clock. We're very happy to welcome you all to this webinar from the Emirates Hand Surgery Society. The topic for this evening is scaphoid injury from fracture to non-union, challenges in diagnosis and treatment. This webinar will be initiated by my colleague from Denmark. And just to make a little correction, on the first page I saw 3 Swedish flags. So I'm from Sweden, I work in Copenhagen. My colleague Morten Kjær, which will start with scaphoid fractures, he is a Dane, as well as Dr. Robert Gostenovich, he's also a Dane. So for that little correction, let's pop directly on to, it's now my pleasure to introduce my junior colleague, Dr. Morten Kjær. He's just back in Copenhagen after research exchange in Adelaide with Dr. Greg Bain. Dr. Kjær has the last years gained a vast knowledge in diagnostic and treatment of scaphoid fractures, which is also the topic of his PhD, which is intended to be defended in the fall of 2025. So welcome, Dr. Kjær. The floor is yours.
So thank you, Marcus, for the introduction. I will tell you about scaphoid fracture treatment and the challenges we have there and give a short perspective in nonunion cases, which is a part of my PhD studies. So first of all, the scaphoid fracture accounts 2/3 of all carpal fractures. It is 10% of all fractures to the hand, and it is usually seen in young males in their 20s, after a fall on the outstretched hand or bolter hand or high energy trauma. We can do some clinical tests if we suspect scaphoid fractures, but none of them have good sensitivity and specificity, so we cannot rely on the clinics. Maybe if we do some supination with restrictions, we can increase our sensitivity and specificity, but I suppose if a patient has a distal radius fracture, the patient will have pain as well with this test. So we can do some imaging to find the scaphoid fractures. We can do an X-ray, but we have to be aware that they can be false negative, and 10% of the patient with a normal X-ray and a clinical suspicion, they have a scaphoid fracture. So we have to continue if we have a negative X-ray, but still have a suspicion. And then we can do an MRI with really good high sensitivity and specificity. We can otherwise use a CT scan, which has a high sensitivity as well, but a bit lower specificity. And then we can use a dual energy CT, which we use in Denmark. It has high sensitivity and specificity, and we are able to look at the anatomy as well, which is really important when we have to choose conservative or operative treatment of the fractures. As an example, you can see a conventional CT scan on the left, where you might overlook a scaphoid fracture, and in the middle pictures you can see the dual energy CT with with high sensitivity and specificity can find the bone marrow edema and identify the fracture. And the images at the right is the MRI, just for comparison. Looking at the incidence of scaphoid fractures, waist fractures are the most common. It is 2/3 of all scaphoid fractures. And second, it is the distal pole fractures, which include the transverse fractures and the tubercle fracture. And the proximal pole fractures is actually quite rare, with only 5 to 10% of the fractures. What is really interesting is if we look at the scaphoid non-union, you can see that the waist fractures, waist non-unions, they are approximately 55% of all the non-union cases. but the proximal pole non-union, they increase from 5 to 10% in scaphoid fractures to almost 45%. So it may give us an idea that we treat the proximal pole fractures not good enough. The risk of non-union, we know that if the patient is a tobacco user, it has a risk of not uniting. If the proximal pole is involved, you have an increased risk of non-union, and if the treatment delay is higher, you have a risk of non-union, and then displacement as well. What we can do for operative treatment is percutaneous screw fixation or open reduction and internal fixation, either volar or dorsal. The volar approach is good for the waist fractures, and the dorsal approach is maybe better for the proximal pole. And K-wires can be used as well eventually if it is a really small proximal pole fracture. What I want to talk about is that we can treat most of them with conservative treatment because most of the fractures, they will eventually unite. But we have some risk factors that we have to look at. And the first thing would be talking about the treatment delay. And we know from Ruby-Grell from Canada that if a patient has a treatment delay from 6 weeks to 6 months, the patients, they are able to have 20 to 82% union if they are treated conservatively. But we have to be aware that this is a non-displaced delayed scaphoid fractures. And from this study, we have to be aware that the proximal pole fractures, they should have cast for a longer period. If we look at the pediatric cases, we have another study here that shows most of the cases, they are actually delayed, but you can achieve 75% union with conservative treatment. So actually the treatment delay, we still have a high chance of union with the conservative treatment. But of course, with the treatment delay, we can see here the odds ratio of non-union increases. The second thing we have to be aware of is the displacement. It can either be a latum dislocation or angulation of the scaphoid, the humpback deformity. And we know from the SWIFT study from the UK, where a patient was randomized either to operative treatment or conservative treatment in waist fractures below 2 millimeter displacement, there were no difference in their outcome 1 year after they sustained the fractures. But what's quite interesting is that 65% of the patients who had surgery, they had screw protrusion. So the question here is would the surgery group have better result if they didn't have that much screw protrusion? But as you can see here, at 6 weeks, they had a bit better range of motion and grip strength, but it was not different to the conservative treatment at 1 year follow-up. It is quite different in the proximal pole cases. And I have just an example here of a raised fracture that you can see in the X-ray. And if we do a CT here, you can see it is just around the dorsal ridge, and maybe the displacement here is below 2 millimeters. So you can treat the case here conservative. But what you definitely should be aware of when you're checking for union, if you don't find any bone breaching, you should maybe change your plan and offer the patient operative treatment. The case here were first seen at 8 months follow-up, where a non-union was identified. He was offered surgery with open reduction and graft reconstruction and eventually united. So with the displacement below 2 millimeter can be treated conservatively. And another study here, we can see if the displacement or translation increases, the odds ratio of non-union increased markedly. And we have to be aware that the proximal pole fractures are quite different. So minimal or no displaced fractures, they can be treated conservatively, and we should only accept minimal displacement. And if they are displaced, they definitely need surgery to achieve union, because the risk really increases for getting non-union if they don't have surgery. According to the cast, if it is a proximal pole fracture, the cast period needs to be quite long, 6 to 12 weeks. If it is a waist, it can be a shorter period for 6 to 8 weeks, and the distal pole can be treated for only 4 weeks cast. An example here of a proximal fold fracture was here a guy with a fall to his hand 1 week ago, and the fracture, as you can see here on X-ray, it's not visible, so it was overseen. And after 8 weeks, he was referred to our department, and he had a CT scan, and you can see the fracture here, minimal displacement, and he was treated with a cast with an 8 weeks treatment delay, and he eventually united. Another case here is a patient with a 3-month treatment delay. You can see the X-ray here, and then the CT scan was done 5 months after conservative treatment. And the question is here, should we treat him conservatively? This case, or operatively? This case were not offered surgery, and after 9 months, he eventually united. Talking about the CT scan evaluating union, we have done a study because we know that X-ray are not good in evaluating union in scaphoid fractures, both in conservative and operatively treated patients. We know in CT scans for the conservative treatment, CT scans have good reliability, but not for the cases who had surgery. So we did a study investigating the agreement between observers in evaluating union on CT scan, because we want to improve our evaluation so patients can have cast for a shorter period if we are more certain that the fracture or non-union has united. We definitely have to be aware that when you evaluate union, you have to look at the sagittal plane of the scaphoid. It is crucial to evaluate the union and bone bridging. So a case here from January, I saw in Adelaide during my exchange. He was in January written up for surgery. It was a 5-month-old treatment delay, scaphoid waist fractures. And when he came in April to surgery, the surgeon was uncertain. And if we do a sagittal plane of the scaphoid here instead of the sagittal plane of the waist, you can see here in January, there was actually partial union of the dorsal part of the scaphoid. The surgeons, they did a new CT scan on the day before surgery, and they saw that the patient were united. So you can overlook bone bridging if you don't look at the correct plane of the scaphoid. But what we did in our study, we included patients who had surgery for fractures and non-union, and who had CT scans 6 to 20 weeks after their intervention. And they were excluded if we used K-wires or rascularized graft, or if they had secondary surgery. And we want to investigate the reliability. We had 60 cases, 3 waiters who was anonymized and evaluated union in 2 systems, no partial or full union, and above and below 50% union. And we did Kappa statistics. 0 is really bad agreement and 1 is perfect agreement. And what we found was that the agreement was moderate in the evaluation of above and below 50% union, and substantial in evaluating no partial and full union. The intra-radar agreement, the agreement between the observer itself, was substantial all the way. If we only look at 2 of the radius, the agreement was a lot better. Another different interesting thing to see here is that if we look at the CT scans, which were done above 12 weeks after surgery, the reliability increases a lot in both evaluation systems. And you can definitely be more certain of your evaluation. And this study shows, even though it was anonymized for all patient data. And the intra-radar agreement improved as well. So for this study, we concluded that the agreement was substantial for the evaluation of no partial and full union, and moderate and above and below 50% union. And the agreement was better in evaluating fractures compared to non-union cases. And you can improve the agreement if the CT scans are above 12 weeks after surgery. There are a lot of practical benefits of CT scans. A case here, it was a proximal bone non-union. He was treated with an open graft reconstruction and graft in the distal radius. And already after 6 weeks, you are able to find bone bridging, so you can remove the cast of the patient. Another thing is that you can monitor the hard cases. We have a humpback deformity here of a scaphoid waist fracture, who was corrected and had graft. And you can see in the middle picture, the question is there bone bridging or not? We don't know. But if you look at the next CT scan, there is signs of union. And you have to be aware that you are looking at the correct plane. And as you see here, when you are in the ulnar part of the scaphoid, when you look at the coronal plane, you should not expect to see bone bridging in the sagittal plane of the scaphoid. But if you look in the central part of the scaphoid, here we should expect bone bridging, and we can see bone bridging. The other thing is that we can monitor if things don't turn out the way we want. This is a non-union case who was treated with open graft reconstruction. And in the upper right picture, it was 6 weeks post surgery, and he has partial union. And then the next CT scans, you can see resorption of the graft, and you can see an decrease of the dorsal cortical angle. And actually the patient, he told me 12 weeks after surgery, first there, that 6 weeks after surgery he had a trauma, and maybe the bone bridging broke out and the patient did not unite. The case here eventually had revision surgery and was lucky that he united with the second attempt. And looking at the scaphoid fractures and the outcomes in long term, we actually don't know how the patient, the wrist function and the long term after treatment. And just a short introduction before Robert will start. We looked at the functional and radiographic follow-up 9 years after treatment of scaphoid non-union, because we know that if we don't treat them surgically to achieve union, patient, they will develop degenerative changes, almost all within 10 years. And our aim was to evaluate the wrist function, and we want to investigate the implication of malunion, because we don't know what a scaphoid malunion is or if it has any implication of the function. So we did a review of all the patients we treated for scaphoid non-union. We found 152 cases, and they were invited for a follow-up with a CT scan and clinical measure and patient-reported outcome measures. This is just a demographic. I will not go through that, but we had 57% raised non-unions in our cohort, and we had 92 patients for follow-up. Most of them were treated with open graft reconstruction because the arthroscopic procedure was first introduced in 2017, and most of the cases were before that, and they typically had a iliac crest graft. And in general, they had an excellent long-term wrist function with a mean quick dash on 8.5. 0 is no symptoms at all, and 100 in the quick dash scale is really, really bad. And we had 92% satisfaction at the long-term follow-up. But looking at the implication of malunion, we investigated the height to length ratio and stated if height to length ratio is above 0.7, will it have any implication of the wrist function? So the left image, we have a height to length ratio below 0.7. In the central part, it is 0.7, and on the right picture, it is above 0.7. And looking at the graph here, we can see with increasing height to length ratio, the patient will have higher quick dash score at long-term follow-up. And then you can see here in the table, the patient, they had significantly decreased flexion, extension, pain during activity, and a higher quick dash score at long-term follow-up. And they were all independent, significant, correlated to height to length ratio above 0.7, adjusted for degenerative changes, treatment delay, fracture location, and tobacco use in this cohort. We also looked at the dorsal cortical angle and found a correlation. So if the dorsal cortical angle decreases, the patient will have increased quick dash scores. But if we plotted the height to length ratio in the regression analysis, the significance, it was not significant. So it is a suggestion that the height to length ratio is a better measure of malunion and has a better correlation to the clinical outcome. The second thing we investigated was the degenerative changes, because if we do not treat them, they will have development of degenerative changes, first at the radial styloid, then the scaphoid fossa, of the radius, and then in the mid-carpal joint at last. So looking at that, patient without malunion, preoperative, they almost had none degenerative changes, and the same at follow-up. Almost 90% had no sign of degenerative changes at mean 9 years follow-up. But when we look at the deformity group, preoperative, they have a bit more degenerative changes, and at long-term follow-up, 55% had degenerative changes. So that's quite interesting. Looking at the complication for the whole cohort, complication was really rare. We should be aware that this is a retrospective study, but only one patient had persistent paresthesia of the lateral femoral cutaneous nerve, and all of the other complications were self-limiting. But we had 26 patients with screw protrusion. Salvage procedures for non-union. And we use the adaptive scaphoid implant quite a lot. It is not common all over the world, but we find it as a really good salvage procedure. So in conclusion, overall excellent wrist function at the long term. Malunion matters, so it has a strong association to decreased wrist motion, pain during activity, and a higher quickness score if the height to length ratio is above 0.7. And it is the first reported measurement of malunion which correlates with the patient's outcome. At last, I will just make a short introduction. We are conducting a randomized study in this topic of scaphoid non-union, comparing the arthroscopic procedure with the open graft reconstruction. We have published the protocol that you can read, and almost 50% now are included and had surgery for the non-union, and we await the results. And this is just a short image that we compare the arthroscopic procedure with graft from the distal radius with the open cancellous graft reconstruction with a structural cancellous graft from the iliac crest. And the primary outcome is to looking at the time to union to see if we can find a difference with the two procedures. So take-home messages here for me is that clinical test for scaphoid fracture has low specificity and sensitivity. So you have to do image. X-ray is really not good. MRI has high sensitivity and specificity, but we cannot see the anatomy and decide if we have to do surgery or not. So the dual energy CT is really good with high sensitivity and specificity, and we can look at displacement and choose to do surgery or not, according to the CT scan. The waist fracture can be treated conservatively if they have below 2 mm dislocation. The proximal pole fractures, we should only accept no displacement, otherwise they should be treated operatively. And even if the scaphoid fracture is delayed, we can treat them conservatively. And you have to look in the correct plane in the CT scan. It is mandatory to assess union, and malunion at long-term follow-up matters for the patients. Thank you very much.
Thank you, Morten, for this excellent presentation of scaphoid fractures. I have myself a couple of questions, but let's start with the questions from the audience. So we have a question from Dr. Carlos Consults, a reconstructive plastic surgeon with subspecialty in facial, hand, and vaginal reconstruction. His question is, are there any prognostic factors to rely on to avoid avascular necrosis?
The question is quite interesting because it is discussed all over the world. Some consultants think that avascular necrosis doesn't exist, and some think that it does exist. You can do the MRI to test for avascular necrosis, but the MRI can be false positive in predicting avascular necrosis. So what we do in our randomized control study, we do not exclude the patient if the MRI suggests avascular necrosis, and we evaluate it during surgery. So if there is no punctate bleeding of the proximal pole, then the patient would be excluded from our study. So the best way to investigate for avascular necrosis is MRI, but you cannot be sure if it is avascular or not.
Thank you. So well, there's a follow-up question on a similar topic from the same attendee. So also, are there any X-rays? Also on X-rays, some take 15 days to appear. Is there any newer modalities to trigger a clinical census? So maybe you already have answered that with the dual energy CT. That will probably be the most modern and the newest way to look at it.
Yeah, definitely. But if there is a 2 weeks treatment delay, the fractures become more apparent on X-ray. So you could start with doing an X-ray to see if there is a fracture, but you should know that you can really not see if the fracture is displaced or not. So if you should decide to do surgery or not, you have to know. So then you have to do a CT scan of the scaphoid. But of course, if it is gross displayed in the X-ray, you should do surgery. But otherwise, CT scans is good in the preoperative planning, so you can be ready to know how to correct the displacement or deformity of the scaphoid. So I would always suggest the CT scan.
Okay, there are 2 more questions. One is it could be a little lengthy answering from you, but so it's a vascular graft versus non-vascular graft. Which has the best prognosis is the question.
Yeah, it is a really hot topic, and there is really different opinions. In our center, we really rare do vascularized grafts. There has been several reports comparing vascularized graft and non-vascularized, and in general, in systematic reviews, there cannot be found any difference of the results in patients treated with vascular graft or not. So for me now, I cannot say vascularized graft is better than non-vascularized. So my recommendation would definitely be non-vascularized because the technical demands are lower compared to the vascularized graft.
Okay, thank you, Morten. So as it's still quite a challenging area, and maybe for some centers to use it as a salvage procedure if the non-vascular graft has been used and it still doesn't heal. So a couple of more questions, but we should soon move on to Dr. Gostenovic. But do you have any aspects on physiotherapy? There's a question regarding physiotherapy to do it early or late.
Yeah, thank you very much. A really good question. So in the randomized study, I see all patients post-operative. So I really have, for the last 2 years, 50 patients with a scaphoid non-union, and I have a quite clear opinion on that. When we do remove the cast after 6 weeks, they are not that stiff in general, and almost none patient required special rehabilitation. So what we do, we send them for an instruction to do a non-weight bearing range of motion. And when they have signs of bone bridging, they are allowed to do a bit force, a couple of kilos, and I instruct them in passive range of motion exercises that I really think it is important to soften the joint capsule that is quite stiff after surgery. And I can see when they come to their 3 months follow-up, they really improved a lot without any special rehabilitation. So it is really rare that they need a therapist in our center because it will eventually regain their wrist function when they start to use it. So the most important thing is to keep the patient in the cast until you see bone bridging, because if you see bone bridging, it will almost always unite.
Yes.
And it's the most important thing.
You said the most important thing. To me, there are several new things here, especially this, that the malunion actually matters. That was your last sentence. Yeah. So just briefly for myself here, a question. So we saw that you had in your center, or our center, 50% of screw penetration, and the similar was in the SWIFT study, was actually if you just include the waist, it would be 50%. of 47, but if you include both the waist and the proximal, it was 71%. So there's a lot of screw protrusions. So which is most important, or which is the worst, screw penetration or a humpback malunion? So I hang to height to lace ratio below 70 to the patient.
Well, you can remove the screw and then the problem is fixed. The malunion, it is suggested to do corrective osteotomies in Hong Kong. They do it. And the professor, Greg Bain in Adelaide, he asked me this question when I presented the results. But what you should know is that we had 92% satisfaction of all patients, which included both the non-union, the salvage patient who had salvage procedures, and the united scaphoids. So all the patients who had union, they were satisfied and they didn't want any new evaluation of their wrist because they were satisfied with their function. So malunion matters. They have decreased mobility and higher symptoms, but they are still satisfied with their wrist function at long-term follow-up.
That's excellent. You actually answered the last question, which I won't pose, but it was regarding osteotomy, corrective osteotomy. So let's move on to our next speaker. This is my senior colleague, Dr. Gostanovic. And so scaphoid non-unions and scaphoid fractures go sort of hand in hand. Unfortunately, sometimes they do. So these topics might overlap a bit. The surgery can be challenging, both the surgery for fractures, but even more the non-union. So to enlighten this topic, we look forward to hearing the next presenter, Dr. Robert Gostanovic. During the last 20 years, he's been working as a hand surgeon at the Department of Gentofte Hospital, the Department of Hand Surgery. He has profound knowledge in the field of hand surgery, with special focus on ligamentary injuries in the carpus, the scaphoid fractures, and non-unions. And other areas of interest are also TFCC injuries, waist and DOJ arthroplasties. So please, Robert, go ahead.
Thank you, Marcus, for this nice introduction. Before I start, I want to tell you a short story. 5 years ago, I met a nice guy in London. He was looking familiar to me, and we approached to each other. His name is Nebojša Jovanovic, and he's actually the guy who made this webinar possible. He asked me if I could use an afternoon together with my colleagues from my clinic to entertain the colleagues from Emirates. And I said yes eventually, and I'm very happy to join this webinar today with you. Well, talking about the presentation, I don't have any disclosures to this presentation. And looking at the scaphoid non-union and the scaphoid bone, which is a tiny bone in the wrist, but this bone can cause so many problems. And the question is actually, why is this injury such a problem? And one of the reasons why this is a problem is that this the patient doesn't go to doctor. Many young men, they misunderstand this injury, and after a couple of days having pain, the pain diminished, and they think, okay, it's gone. So some studies actually concluded that 1/3 of patients never go to doctor. They turn to doctor in the late phases of the problem, when the degenerative disorders are already started. 1/3 does go to doctor, but either because they are misdiagnosed or ER, for instance, they are taking the wrong X-ray, or somehow these 1/3 of patients are coming to the surgeon in some delay, with some delay. Only 1/3 of the patients are actually treated in the timely manner and with a proper treatment method, which Morten was talking about. So why it is dangerous? It is potentially very dangerous because if untreated, if left untreated, then the avascular necrosis can be seen as shown on the left picture, where the proximal pole is poorly vascularized, or if the dizzy deformity occurs, as in the middle picture. And eventually, left untreated, the scaphoid non-union advanced collapse will occur in all cases. One of the classification is the Slade and Geisler, which I like. The first three types of the problem, meaning stable injuries, relatively more easy to treat, while the last three stages are unstable with larger cysts and resorptions, and even with a gross fragment motion when the problem begins to start. So I prefer even more another classification, which is called Moritomo, and it is defined whether the fracture line ends proximal or distal from the dorsal ridge. So if it is distal, then it's called a volar type, always ending in some kind of humpback deformity. But if it is proximal from the dorsal ridge, then it usually ends in a kind of shearing-like deformity, meaning displacement. I'm going to talk a little bit more of this dorsal type a little later on. Talking about different timings, we divide things into acute, where still some nice healing can be achieved, whatever treatment you use, especially if it's undisplaced. And I think Morten explained a lot of these challenges in these early stages. If something is delayed, we call it when it's usually between 2 and 6 months post-injury, and the established pseudarthrosis or non-union, as we call it, when the things are more complicated, above 6 months from injury, where usually some angulations can be seen. Talking about the classical treatment methods, back from 60s, Matti Russe established the technique, taking the iliac bone graft and putting it into the gaff, which is previously being cleaned. And in the beginning, no fixation was used, but after some time, surgeons started to use key wires and screws, and results improved significantly, while the union and recovery rates still can last several months. Then the vascularized grafts started to be popular, and whether you use the dorsal or a volar, you use always a bony window taken from the distal radius usually, and then placing it into the gap of the scaphoid non-union, which needs to be cleaned. So on the left side, you see the dorsal type of vascular graft using the retrograde intercompartmental artery. And on the right side, you see the Matulang graft, which is using the volar branch of the radial artery, which is my preferred technique for the distal pole non-union in salvage cases. There was a question about which technique is better. And it is true, like Morten explained, that the systematic reviews using more than 7,000 patients tried to discover if there was any difference. And union rates between these techniques are very similar, 88 and 87%. So no difference, whatever technique you use. If you thinking on which graft is better to use, distal radius or iliac cleft grafts, and also these results are very comparable measuring the union rates, 87 and 87.6 respectively. First time I've heard PCHO, I think it was in FESH meeting in Paris 1914. Then I started to use the method back home, and I only treated several patients in the first couple of years, but now we are very confident with the method. The method contains using the mid-carpal portals, usually MCU, MCR portals, and sometimes using additional 1-2 portal, where we clean the gap using the shaver, arthroscopic shaver. Then we host the graft from the listus tubercle using the aspiration bone needle or even small curette. Then we morcelize the graft manually and transport it with a second trocar into the gap, and then we try to impact the bone, and then we finally place the key wire and the screw without penetrating the cortex. Very important detail. So that means that you have to measure the screw very profoundly, and now we know from studies, I can explain later, how to measure it, the scaphoid length. I defended the thesis on this topic, and the title was the CT scan measurements as an assessment and arthroscopic bone grafting as a treatment method. And I'll just shortly go through to some most important findings. We look at the normal values of the most used CT measurements of angulation, which are height to length ratio, lateral interscaphoid angle, and the dorsal-cortical angle. Because it's improper to call somebody malunited or deformated without knowing the normal values, which were poorly investigated back then. So we measured 30 women and 30 men and found that the normal ratio is 0.58, but look at the ranges, all between 0.5 until 0.70 were actually normal values in people. So dorsal-cortical angle was normal in 128 degrees in both sexes. So I think when we're looking at this X-ray, CT scan on the right, we can all agree that we need to correct this deformity. But how good are we in correcting this deformity? Because the opponents of the arthroscopic bone grafting, they think that the deformity cannot be corrected if you do it arthroscopically, and then if you do it openly, that then you can make a great wedge graft and put it in the gap and control your correction, right? And also another question is the Hampeck deformity really a good predictor of union after surgery for this condition? And we look at the data retrospectively, and we can see that no matter which method we use to treat the patient, and no matter which method we use to measure the angulations, there were no significant difference between techniques. Open group corrected only 4 degrees the deformities pre and post-operatively, while the arthroscopic group only corrected 1 single degree. And only if we, also if we use the height to length ratio, the measurements were totally insignificant. So we are not so good in correcting the deformity, although we think we are good, but we are not. And looking at the Hampeck deformity and the impact on the union rate, no matter which method we used to measure, we couldn't see any impact of the preoperative deformity to the union rate. Although we could see that the displacement at the waist, if it was larger than 3 millimeters, then it had an impact on the union rate. The other thing which had an impact on time to union was the time from injury to surgery. So the longer the time up to surgery, the longer the time from surgery to union. Several papers look at this question of malunion, and several of them couldn't see any clinical relevance in patients after surgery, although one single study back in 18 could demonstrate that dizzy deformity can occur if the height-length ratio is above 0.70, so 0.70, but not more. And an important study from Stockholm looked at this problem too, at 7 years follow-up, and the only thing they found changed in the deformity group compared with not deformity group was a slight worsen of extension of the wrist as the single bad thing. Our own data has been shared from Morten previously, so I won't go to details. So there are some small changes in the 8-year follow-up, but also the question is how clinically relevant they might be, even though if they are statistically significant. I will just add to this debate about what matters more, malunion or not. I would say that what matters most is union. So if somebody's united after surgery, they're happy, even if they are in small malunion. And then the question again, should we correct the deformity? Of course, yes, we should correct it. We should try to correct it and try to correct it properly, but everything up to a height-to-length ratio of 0.70 is tolerable. So we should relax. We should use the method we are confident with and think only if it's more than 0.70 before the operation, then we have to have a strategy how to correct it. And can this correction be achieved by arthroscopic technique? The answer is yes. On the left, you see the preoperative, and on the right, you can see the postoperative CT scan, and the patient was corrected by using the arthroscopic technique. And how? Well, this method is published before by a group from Madrid and Brazil, and they always start with using a Lynchite maneuver, which is placing the key wire from the distal radius to the lunate to correct the dizzy deformity, and then they retract the wrist and pointing dorsally, and then placing the key wire centrally from distal to proximal, and put the graft and finally the screw. I use a slightly different method. I use a method of reposition, which is usually used when you take the Watson test, which you place the thumb on the volar part of the scaphoid distal pole, and on the posterior wrist, you actually push the radius towards the volar. That's the maneuver which is good in correcting this deformity. And then you make sure that your key wire is placed previously into the proximal pole. Then you can ask the nurse or your assistant to further down drill the central wire after reposition of the deformity. And like Morten explained, we are waiting for the results from our randomized controls trial, and we hope in a couple of years, maybe 1 year, we will be finished with the study, hopefully. Our recommendation to finish with, in acute settings, up to 2 months post-injury, we recommend casting this injury if it is undisplaced. If it is displaced, we usually perform a percutaneous pinning of the fracture. In delay settings, between 2 and 6 months, we can still use cast, but only if it's undisplaced totally. If it's displaced, then we consider placing the percutaneous screw, but actually from a small pilot study we did several years ago, we found that in the late settings, cleaning the gap and putting the small graft taken from the distal radius and doing the arthroscopically can enhance recovery by several weeks more fast. And in non-union cases where the greater instability is found, use whatever method you find confident with. Just make sure that you are doing as soon as possible after injury and try to correct the deformity on proper way. Just a case demonstrating that the surgeons doing these kind of reconstructions need to know all the armamentary of treating these patients. This guy was presented 2 months post-injury in our clinic, and he was fixed very beautifully by our younger colleagues several years ago, but eventually ended up in the non-union of the something we call the proximal pole. And well, then we couldn't find any bleeding from this proximal pole. Well, when we opened the non-union site from volar, and then we had to place a volar vascular graft taken from the a radial artery, so-called Matulang graft, and we eventually placed many key wires to avoid compressing the graft in the middle, and the patient eventually healed after 3 months post-operatively. So the take-home message from me, take-home message number 1 will be, if you can, make the settings back home in your clinics to avoid misdiagnosing the fracture. Use always the proper diagnostics, meaning in the acute phase, either MRI or a dual energy scan. But when you have to assess the fracture to see if there is angulation or cystic deformation or anything, then the CT scan is better tool than MRI. And always use the sagittal plan in the scaphoid axis, as Morten also emphasized in his presentation. And please use the surgical method you're confident in. Do not start using arthroscopic bone graft method if you're not experienced wrist arthroscopist. There are a lot of courses around the world to attend, from Strasbourg to Hong Kong, even on the Arabic Peninsula, as far as I know, but also in Nordic countries. We also do these courses probably every second year. There will be a wrist arthroscopy course in Finland this year, just before FESH. And take-home message 2 will be the watch out for this Moritomo dorsal type, which is more dangerous. If the fracture ends proximal from the dorsal ridge of the scaphoid, then no matter how good you are in doing surgery and how good is your cortical graft or whatever type graft you use, it can end as a disappointment both for surgeon and for the patient. And we look retrospectively on our own series and found actually the odds ratio for the non-union after surgery were double as high for the Moritomo dorsal type compared with the Moritomo volar type. And it was not significant, of course, but I think still it is very clinically relevant. That's what I had to say about the scaphoid non-union. I want everybody to join the newly made association, which is called European Wrist Arthroscopy Association. Our General Assembly will be held at the last day of the FESH Congress in Helsinki, which would be on Saturday. Thank you for the attention. I'm looking forward for your questions.
Thank you, Robert. So we have a couple of questions that's come in. And there's one question that comes and follows from a little bit of what you mentioned, use a technique or a procedure that you're familiar with. So single or double screws, any benefits? And what are your experience of this?
Thank you for this question. This is a very wise question. I usually place 2 key wires to prevent rotation when I do the fixation. So I usually use one single screw, but I make sure not to rotate the fragment which is anterior to the screw, because if you only use single key wire and single screw, then you can rotate so much that it will actually displace the fracture several millimeters, probably 1 or 2 millimeters. So to avoid that, place always a parallel or another key wire to avoid rotating the fragment. And yes, it is possible to make double screw, and if you need to put the double screw, do that. I also did it in some cases without any problems.
So when you say 2 K wires, you mean the 1 K wire that you place centrally, that's the way you do it, and then you have one that fixes the fracture so it doesn't rotate.
Exactly.
Yeah. Okay, so we have another question here regarding, so in cases of chronic scaphoid non-union leading to snack wrist, what are the indications for partial versus total wrist arthrodesis? You showed an image of a partial wrist fusion. So, and how does this choice impact the long-term function and quality of life and the overall range of motion?
Thank you for this question. It's very relevant. We always perform a CT scan of the patients and assess the lunate fossa with the CT scan, meaning that if there is no degenerative changes in the lunate fossa, then we can do the limited carpal fusion, meaning taking the scaphoid out and then making a limited carpal fusion where we fuse usually lunate and decapitate. So the indication is it could be a vascular necrosis, it could be a snack wrist or slack wrist, and you should know that there is around 20% of complication rate after this surgery, and they usually end in losing around 30 degrees of their preoperative motion. But the good thing is they don't have any postoperative pain. So if they heal, they usually do not have pain. They just lose 30 degrees of volar dorsal motion. And looking at averages, so preoperatively they probably have something around 90 degrees total volar dorsal, and it ends to 60, usually, in average.
Very good. So there was one question that came up earlier, actually, I skipped because of the time was sparse. We maybe can address it here, then I will finish off. So how about treating avascular proximal fragments with non-union? It's a difficult one.
It is difficult, but it's, as Morten said beautifully, you can't trust the MRI scan. Sometimes you can better see it on the CT where the proximal pole looks very sclerotic. Then you should watch out, because when you open or when you do it arthroscopically, then you can probably see the very sparse internal bleeding from the proximal pole. And if you do not have any bleeding, then any fixation method will probably fail.
Mm-hmm. Okay. Well, I think that we tried to keep the time, and we have done so. So of the 180 registrants within the Emirates Hand Surgery Society, we have 95 attendees to what I know the latest number. So we have us from Denmark, Saudi Arabia, United Emirates, Arab Emirates, Georgia, Qatar, United Kingdom, Iraq, Pakistan, India, Egypt, Morocco, Kenya, Oman, Sudan, Vietnam, Montenegro, Albania, Kuwait, and Lebanon. Some of them not attending, but this is the crowd that we have had here today. We hope you have been entertained. and that you also have learned a lot. If there are any further questions, please continue to pose them either through the Q&A or to the Emirates Hand Surgery Society, and we'll try to respond them post-webinar. Thank you for this. Over and out from Denmark.
Thank you.